AJ, how's it going?
It's going good. We're getting set up.
Good deal. And you're able to.
Just to confirm, last time we were not able to see who signed up on Zoom, right?
I think we were able to see it, but especially if Hannah is able to kind of monitor the chat and then kind of take a little bit of attendance to see that, that'd be great. And I can help with that too.
Yeah, sounds great.
Hannah, how are you doing?
Good. How about you guys?
Doing well. I'd love to be there in person, but I have COVID.
Oh no!
I don't know what the
I'm
heck
so
happened.
sorry.
Yeah. No.
How is that affecting your rotation?
So far, I mean, I'm obviously not there, but I've been joining the conferences in the morning on Zoom and whatnot. Fortunately, I just had a really good experience. I did a rural surgery rotation for general surgery and got to do some orthopedics out there. So I'm on orthopedic surgery this week.
Oh, nice.
In the next 2 weeks. So missing that, but otherwise, yeah, we're okay. So all things considered, could be worse. I'm thankful.
And what was your name? Sorry again. Hannah. Since it's first come, first serve, if you want lunch, feel free to get one. Eating is after the meeting, of course. Yes.
Okay, good. Hey, the Zoom is working good.
Aaron, how's Wakini?
Oh, it's good. It's getting more and more boring to stay out here. We just have clinic today, so I just got home. I live a minute away, so. And AJ, if you want, you can have the video. Can you hear us, AJ? Hey Jack, how does the video look? How do the slides look on yours?
Yeah, they look like it's just a sliver of it.
Yeah, that's strange. Hey AJ,
You are signed on to the because I muted mine, so I don't know if anyone is saying anything.
Oh,
Okay. Does it get better? No, still half. What's that?
that's better.
No. Okay.
AJ, is it possible that you're sharing, because we can see this. I can see the whole slideshow when it's here.
AJ, are you trying to use presenter mode, or is there a difference between presenter mode and just slideshow? Because it was looking good before, and then it went back to cut. I didn't know if I forget. He can't hear me, can he?
He can hear you now.
Oh, he can. Okay.
Hey everyone, welcome. We're just trying to figure out some technical difficulties. Sorry about that.
Hey guys, I just wanted to let you know I'm just finishing up in clinic, so I've got another patient to see. So I'll log back on in a couple of minutes. You guys just go ahead.
Okay.
All right, hi everyone. We will get started. Let's see. It's almost 12:08. Welcome everyone who is here and online. Can you guys hear me? We just need one minute. All right. So I'm gonna start with introducing ourselves in the room, and then also some of the new members we have for the KUMC chapter of GSSA. And thank you for interest with everyone here. So I'm AJ, I'm a second year medical student. I'm a co-president of the chapter. Then we have two new members here and one member online. So I will let them introduce themselves. Name and class.
Hi everyone, I'm Samira Ali. I'm the social chair for GSSA. I'm just starting off. So far enjoying it and welcome.
Hi everyone, I'm one student as well. Think events here or something like that. What's the other job?
Yeah, they are just starting, and then we have Hannah who is online.
Yes. Hi, I'm Hannah David. I'm a
but
first
she's
year.
the
Yeah,
third
joining you
and
guys
newest new,
online.
officer of the chapter. So in this particular meeting, and then we have Dr. Corin Teger. He's a plastics physician here at KUMC, and he's the chapter advisor. And I think he said he was busy, but he will try to log in at some point. And if not, then he will be presenting one in December. So there will be a meeting to look forward to. So what I'm going to summarize here is, and then we have other two members online. Aaron Blake, who is a third year medical student, and then Jack Iris, who is also a third year medical student, and they are on the rotations and stuff, so they are not able to get here in person. All right, with that, I think I will get going. So what I'm gonna present here today is like sort of why sort of this group, Global Surgery Student Alliance, was started, and like some of the things that are driving it. So Lancet basically, the Lancet Commission on the Global Surgery was itself launched in the January of 14. And the idea was that while there has been a lot of development that is made in the Western countries, the low and middle income countries have not caught up or have kept pace with the sort of health facilities they have in place, and like access to the care as well as affordability, right? So what this commission basically did was did a sort of analysis of what is present at that time and what they should target for 2030. So about 15 years and how to get there. So I won't be going through everything because it's a pretty long report, and I'm gonna send out a link to for you to whoever wants to go into detail and look at it. But I'm gonna summarize some of the like key messages that were found in the report. And so the evidence and the solution for achieving the global health, welfare, and the economic development. And the 5 key messages of the inequity and impact. And this is the first key message. That overall, there are about 5 billion people who lack access to the safe, affordable surgical and anesthesia care when they need it. There were like 4 dimensions. They divided the access is. First dimension, time it takes when someone is injured or need care to get to the hospital. Once they are in the hospital, what is the capacity of the hospital? Like just getting to a care center doesn't mean you're gonna get the care that you specifically individually require. How safe is that procedure? And then the affordability of the procedure itself. While most of us who have not traveled internationally, we are very familiar with the concept of health insurance, but in most of the low income and middle income countries, people pay out of pocket for their healthcare, right? So don't have insurance. Now, in absence of that, depending on what procedure or type of care they need, that could be a very big out of pocket. So we are talking about people going bankrupt, or just not able to afford the care in the first place, even if they are able to borrow it from someone, right? So in the figure here on the right, you can see most of Africa, Southeast Asia, and basically any countries which are usually populated, has low income or middle income. They are the countries who have been suffering. And so what are the reasons for delay? So like the commission went into like what is likely driving it. So we are looking at here, like they don't have reliable electricity, they don't have running water, oxygen supply in the hospitals. They don't have a sort of emergency area, designated emergency area. And even if they do provide the operative care, they don't have a post-operative care. So people have to, either go home or go somewhere else to get that. And then often they don't have equipments, but if they do, they usually don't work. They're not able to repair them, or they are foreign. So, like someone from outside needs to come and repair them. They don't have radiology, absence of safe blood supply, and then the tertiary hospital. So tertiary hospital is something where you have like the trauma facility, and like where a lot of most of the big surgical procedures are done. So due to the reason that there are very few tertiary hospitals in these areas, they are overcrowded, so they exceed the capacity 2 to 3 times. Don't have the managerial support. The government and public officials in most part are corrupt, and then there is a discord between services that are most needed and what are available, right? So the 3 delay framework, well, then they define it for a little bit more. So first delay is in the seeking of the care itself. So in areas where there are like local healers, not physicians, like not trained physicians, but like local healers, like the Chinese medicine or the Indian medicine, they would first go to them instead of the hospital to seek care, especially if they are poor, and based on their cultural beliefs, the locality, and so 80% of them rely on informal providers. So that's a huge number. Like when we get sick, first thing we think about is physicians, but coming from some of those areas, you don't have readily accessible physicians. So you end up with people who are not trained to do provide healthcare, providing those services. So there is a lot of heresy. There is a lot of old beliefs which may or may not work today. The second delay itself is in reaching the care itself, as in hospital. So there are not enough hospitals. And then second, transportation, like, very few people outside the Western countries have their own personal car. So they rely on the public transportation to get to these facilities. Again, due to the lack of transportation, that facility may or may not be there. So that reduces the way they can get to the care itself. And then the third delay is the delay in receiving care. Just because you are at the hospital doesn't mean that you're gonna get the care, right? You may not be able to afford it. It may be a hospital which does not provide the C-sections or lobotomy or treatment for any open fracture, right? So those are the things which we are not familiar with in general, but they exist outside, in other countries where there is not enough care. So what is like based on those delays, how that can be tackled is reducing the first and the second delays. So need to have a strong pre-hospital network. So not necessarily physicians or care providers, healthcare providers, but someone who can act as liaison, right? So care centers, rapid response ambulances, we can get people there. Community participation is something, again, training students basically to provide some of that link between the physicians, hospitals, and the patients, and if possible, bringing the care themselves to the patients. And then the third delay, as we saw, was the hospital itself. So once they do get to the hospital, how can we reasonably guarantee the treatment? So there need to be some core delivery sites for surgical care at the hospital, providing a broad range of surgical anesthesia services. And then bellwether procedure is something which has these three things at the least: laparotomy, C-section, and then treatment of open fracture. Because if we are able to provide these three, we are at least have a good start, because those three things cover the top three needs of these areas. So we covered the first message. So the second message out of 5 is that there are 143 million additional surgical procedures that are needed each year to save lives and prevent disability. So it's a huge number. Again, 12 of the 20 global burden of disease, they don't have enough procedures to address the basic surgical needs of their population. And then regions with the greatest unmet need are most of the sub-Saharan Africa, especially the Western, Eastern, and the Central, followed by South and Southeast Asia, as we saw in the graph earlier. So I'm going to start here with the plot on the right. As you see, like as the number of surgeons, the workforce, number of care providers increase for 100,000 population, you start to address almost one-to-one, right? So if there are more number of surgeons, anesthesiologists, and obstetricians, you are providing pretty good care. But this is where the problem area is. And this is what is happening in most of these regions that we mentioned in Africa and Southeast Asia, that there's only 12% of the surgical workforce that practices in these areas. And so basically the task shifting there is that redistribution of the task among the health workforce teams in these areas to better provide healthcare access to these populations. In terms of how that could be done, the redistribution, so the training programs, which could be used within the cultural context of those areas. So train the trainer. That trainer could be a medical student, could be a nursing student, could be the liaisons between them and the hospital. Also, other thing that may happen and does happen is that once you start practicing in some of these areas, there may not be a concept of continuing medical education, right? So whatever time they learn something, if they are still doing that for 10 years, 20 years, 30 years, then they are not providing like up-to-date care for their patients, as well as procedures they are using. So some of the ideas that the commission suggested was using like online, telephone, internet certifications, training that can be provided in these areas versus in-person training. Then on the same track, key message 3, this is about the affordability. So there are 33 million individuals which face catastrophic health expenditure due to the payments that need to be made. So again, just people fall sick all the time, obviously, and living in a high population density area, there's that much more chance to get sick or require a procedure. So majority of these areas don't have that facility and cannot afford the out-of-pocket cost. And similarly in these areas, if you look between the poorest and the richest patients, they are like 61 times more likely to face the catastrophic expenditure compared to the richest patients in those areas. So there is a huge income disparity. So, and then how can we make the investment in the surgical and anesthesia services, which is affordable, which saves lives and promotes economic growth? So like what commission sort of basically said was that it's a investment in surgery in these areas is a highly cost-effective intervention. So for like every dollar you put in surgery or such services, there's more than a dollar you make back based on the sort of economic growth that that care provides to the population, right? If people fall sick, they cannot work, so we are losing economic growth there. So this is a percentage of annual health expenditure is proportionate to the percentage of total burden of disease in these areas. It has substantial economic returns, and then if we don't address it, don't continue to address it, there will be the projected cost is 20.7 trillion, or 1.3% of the global economic output. Two things which has the greatest effect on the economic output is neoplasms, the cancers, tumors, and injuries. And then LMICs is the low and middle income countries. Surgical conditions, as much as 2% of this annual GDP suffers because of that. And then the last key message, that surgery is a basically integral part of the healthcare, and for example, increase access to C-section, C-delivery, reduces the mortality by 30 to 70%. Infectious diseases, injuries, which are the largest subset of the global disease, addresses that. And then basically idea is to integrate the surgery into the local district hospitals and use it as an enabler to advance the global welfare. So pro-poor approach versus some of the other things that have been done in the past to finance the surgical care. Now, this is one area which, when I was sort of reviewing the slides and the commission report, that stood out is like something where like the students like us can make the biggest impact. That there's a huge lack of uh, local knowledge about like what is lacking, what needs to be done. So there is an absence of the local research on the local areas of need. What you and I may think is what these people need may not be true, because they are the one who actually need that, and they are the best people in the position to tell us that. So that some of the global research is missing. So basically coming up with partnerships with some of the local providers there to provide us with some of that knowledge and to better prepare the programs to satisfy their needs. And then the training funding, all that is obviously more, the next step, but the partnership is something which can be started by some of us here or on the university level as itself. I know like there's a few faculty members, Dr. Corinne Taylor, our advisor included, who has done a lot of such partnerships with other hospitals internationally, and we need to continue doing and have more of those with the student participation so we get a better idea. This is basically just the summary of the key messages: timely, safe, affordable care, capacity, surgical capacity expansion, investment in those specific services itself, decreasing the health expenditure, so addressing the affordability, and then making the healthcare as a very integral part of the society. And that's about it. Any questions? Any online questions?
No, I think you did a great summary. I'm actually heading over to the HEB now, but no, I think that's a great summary of what the problems are and how, some sort of general thoughts as to how we're going to be able to start to address them.
Is there any yeah, if there's any discussion that anyone wants to raise up, there's still time, and there's if anyone has questions or wants to raise any discussion points. One of the things is, like you pointed out, I was going to ask was, how do we, effectively as students, do you all think that we can become active? And also, if you have contacts for people who you think would be good to have talk to us, or you want to hear from, for example, if students in the audience, I don't know who's all there, if there's a field specifically that you want to get involved with or you want to hear more about, let us know too, because we have contacts who we can reach out to, and we can try and engage you guys and see where you guys are coming from and see what things you might be interested in. So I don't know who all is there, but if anyone has anything, feel free to speak up, now, or you can email us. But that is something that, engaging students early on and figuring out what we like and what we want to learn more about, and we can bring that to you guys.
AJ, we have a comment in the chat here from Sophia that Dr. Kovac, who's in anesthesiology, often speaks to medical students. He's in Lima, Peru, so he could be a good speaker for us.
And then I don't know how to do it. Could you maybe just come over here and repeat your question?
I can, sorry, this is Sophia. I can talk a little bit about it. About Dr. Kovac, is that what you're asking, AJ?
Sure.
Yeah, I think he would be a really good contact to talk to. He actually makes frequent trips down to Lima. And he also has contacts as well as in Africa, all over the world, where he does specifically like work with anesthesiology students. And I know that he's also very big about like potentially assisting students to go visit the schools that he's partnershiped with. So I think in general, he'd be a great speaker to talk to about his experiences and how he like came about working internationally, but also if anyone's interested in facilitating a trip, I think he's a really great contact.
Awesome. Thank you, Sophia. We also have a question in the room, and I will just let her ask that directly. Probably more applicable to Dr. Korentega.
Okay, so you partially answered the question, Sophia, but I was wondering if there were any other programs that, or like outreach programs that have been done in these countries that need the surgeries in collaboration with the hospitals or doctors there. And I was wondering if there was any plan to do that in the future and how can we be involved?
Oh, with with our university students, is that what?
Correct. Yes.
Oh, okay. Dr. K would have, I only been here for 3 years, but as I understand it, typically, there's much more focus with our school on the internal med aspect. Oh, there's Dr. K. I don't.
Hey, yeah, sorry, I'm like walking over and I keep keep losing my connection. So there's a lot of things that are going on through the school and through the Office of International Affairs. And one of the things that we're trying to work on is to create sort of a clearinghouse so that everybody, is aware of the things that are going on, because there are things in a lot of different groups. Dr. Kovacs is superb and very careful and thoughtful about how he does things. And as you say, he's been involved both in Africa as well as Peru. Our department is involved in Guatemala, but we're also developing programs in Africa specifically related to burn programs. You've got Dr. Headings in orthopedic surgery, the orthopedic trauma surgeon. He's got a very close alignment with Romania, and he's had Romanian surgeons come here, and he's gone over there multiple times. It just sort of, honestly, it just goes on and on. Locally, InMed is a very strong local group that does a lot of international sort of education and international development. So there are definitely lots of opportunities, I think, and we've sort of talked a little bit about this before. I think one of the key things is going to be to choose something that is sort of small enough and achievable. If you can just make, an impact in one area, sort of pick an area, that works well. As you said, the school, we've got the trips that go to Guatemala. I think that would be a good way to do it, because, when like in the presentation, you saw it's such a huge problem that sometimes it's a little easy to get discouraged because it's so big and broad. So I'm going to keep walking over there. So hopefully I'll be able to make it with you for at least the last couple minutes.
Yeah. Hi, this is Samira. I was just kind of curious, like where specifically in Africa are some of these programs being set up?
So for Dr. Kovac, I can't remember the exact countries. We can reach out to him, but honestly, I think if you Google him, you might be able to.
Specific.
You might be able to see, but I think Ghana, I believe I was in a presentation of his not too long ago. I can't remember exactly that country, but we can reach out to him to figure out.
Thank you.
Also, so someone had mentioned InMed. Also at that meeting, Dr. Comnilius, he is actually the founder of InMed. I think he'd be a good person to talk to as well, because he has contacts specifically, I think in Costa Rica, for surgery that he works with a lot. And he also like encourages students to go travel with them. So we could talk with him about that. And then also potentially, I was thinking, maybe just getting in contact, since we have like Kovac who works with students, maybe we could do something like just reach out to the students that are in other countries and just kind of build from there.
That is one strength with like this organization. The Global Surgery Student Alliance is part of a larger national conglomerate of schools that collaborate. And, we're a very new chapter, but, going forward, there will be hopefully some opportunities where we can collaborate with students, specifically to hear from other students in other countries, and not just, across this country, but in other countries. And that would be a pretty cool opportunity. And so, yeah.
In addition to that, I think there is also on the Global Surgery Student Alliance website, like there's a, like if you want to look at any specific data, there are data sets which are available. All you need to do is register and you can access the data set for, for different projects that you want to do. Any other questions before we wrap up? Does anyone wants to add something?
I'm going to have to leave in a second for clinic, but just a reminder to anyone who hasn't already, please go follow, I guess, on the beat, the Global Surgery Student Alliance. We want to get as many of you added on our roster, so that way we can send emails out and send updates. There's some pretty cool opportunities offered by other schools, actually. So things like hackathons, and then lectures given by people from other schools and across the country. And we can't just, I don't want to keep sending it to the whole student body. So if everyone's able to follow us on the beat, then we can have a targeted email chain and we can send those opportunities out to everyone. So that's going to be really important going forward for us. But thank you guys, and thanks, AJ. I got to head out, but good talk.
Sounds good. Thank
And
you,
some of
guys.
you who want to wait, Dr. Corntager will be there soon. So if you have questions for him, he'll
He's
be over
working
there.
over here.
That's what he said. Yeah.
Oh, okay.
There. So anyways.
Yeah, he's here. So if you want to come over here, Dr. Corntager, maybe you can take some questions if anyone has any further ones.
Always going to be loaded down.
So I think that all of the things that you guys are saying are great. The hardest thing with this is the world is a big place, and it's really challenging at times to not get overwhelmed. So I think as the KU Global Surgery Group, I think what would be nice would be focus on the things that we can really affect, we can really impact. So I love the idea of the collaboration with students. So I can tell you, when I was in Uganda a number of years ago, I did a ton of surgery, but one of the best things was the collaboration that I had and gave a whole series of lectures to the medical school. And there were, all these students there sitting in a gigantic, basically empty room, and they were just like sponges. They were just so anxious to get any information and they were so well prepared. They were as well prepared as any KU students I've ever had. So I think providing sort of access in that way, finding one that we can collaborate with. We've got, so as I was saying, I think, Dr. Kovac's phenomenal sort of person for us to work with. He and I have been working together a number of years on programs ranging from management of things in India to things in Africa. One of our residents, Sterling Braun, has got a close connections. His wife is from Ghana, and so very close connections there. And we're talking about, trying to expand that and go over there. So I love this whole idea of seeing if we can find a school that we can collaborate with, and then we can sort of grow that. I can tell you that in our plastic surgery society, that's the direction that we're all going. Everybody is moving towards doing things other than just, parachuting in, doing a bunch of surgery and then leaving. It's all about trying to do something that's sustainable. So we can make a difference in one small pocket. I think that's what we need to do. We end up putting a sign up, sister medical school is blank somewhere. And then you develop that long-term relationship. I think that would be if we could do that, then that's also something, and we talked a bit about this the other week when we met, fundraising, right? If you come to me and you say, listen, I need $1,000 for, our organization, like, okay, what are you going to use it for? If you say, I need $1,000 so that we can get these computer programs and we can do this and we can do that and I can really see what you're doing, I'm going to open my wallet, right? And so that's the other reason that I think it's really important for us to focus, what we're doing. If you use one site as sort of a proof of concept, then you just pick up that program, you move it to the next site, right? And there's just great opportunities there. Does anyone have any specific questions or other things?
I think I have one question, like how do you go about identifying, let's say, the first school you want to work with?
You talk to people like Kovac. He's a great person. Devil Buffsar, one of my partners, would be a really good person in that. I've met with a whole series of medical schools in Chela, which is Quetzaltenango, the second largest city in Guatemala. So, we've got some contacts there. We've been continuing to do telehealth with them. But I think getting Dr. Kovacs involved, I think he's sort of the perfect person. He's got, I don't even want to say how many years of experience in this. And then again, we've got, if we're thinking that we'd like to look maybe in Africa, we can absolutely, between sort of boots on the ground and some, people that we know, stuff that Dr. Bobsar has done, and I can't remember if it was Nigeria or where, but we've got lots of connections with Ghana, and we've got connections, a couple of other countries. But I think that's, there's such a need. There's such a need, and the students, I think, going at it, as I say, going from that direction would be fantastic.
Any other questions online in room?
So, the one thing that I will add to this is whenever you're thinking about these things, it's one thing to think about doing, telehealth, teleconferences. Those are things we're doing that with India on a monthly basis, and that was extremely effective because we would alternate. One week we would present to them, the next week the next month they would present to us. So, it's that understanding that, we're going to teach you, you teach us. So it's a two-way street. It's not just, we're going to tell you what to do. So that's very important. The other thing that we always have to be extremely cognizant of is safety. Because just about every trip I've ever been on, at the beginning, we're always being told, listen, this is what you can do, this is what you can't do, this is how you have to think about things, because it's, in some of the countries it's going to be different. And if you look what just went on in Haiti, where, there were 16 people who were kidnapped, I don't quite understand why they would have been there in the first place, but that's another story. But we've got it, that's always going to be things that we have to think about. But I think we've got a great, sort of base of things. I think what we need to do is going to be maybe start to, if you get somebody like Kovac as our next, and then we decide, okay, this is what we're going to do. And then we just set up timelines, start to get it done. And we think if we want to look at building this organization into something where, there's going to be a yearly trip, then, we have that, those take a long time to develop those programs, but we can absolutely do it.
Thank you so much.
Okay.
And I just wanted to kind of share, I think some people kind of dropped into the meeting and dropped into the organization. So kind of sharing where we are as an organization would be nice. Just a little summary, like how come we're like kind of planning things from the ground up, and like who are we? Just a tiny summary of that.
Yeah, so as Samira said, like we are a pretty new organizations. We just started this fall. The GSSA itself is a pretty new organization, and that's why like we are like open to ideas and have like sort of some steps in mind that we want to do, but like we are pretty much working it from the grounds up. So whatever partnerships we need to identify and establish. If anyone is interested in specific ones, if they know someone who is already abroad and such a like partnership can be fostered, that would be a good start. Definitely worth discussion, because right now, like we are basically sort of brainstorming, like how can we make this group the most useful to the students, right? Because we are in the position right now where the more we learn, not just the problems here, but the problems in general in the outside US, it's just gonna broaden our understanding and perspective.
Yeah, I agree. And I think, AJ, I would just add one of the reasons why you keep hearing us say something to the effect of, well, that'd be a good person to bring in, or that'd be a good event to have, is because the reality is we kind of have a shell that's provided by some of the national organization about what we can do. And it's kind of been our central challenge, which is to say, like Dr. Korentager said, the world's very big and the problems in it are massive. And so, how do you, as a medical student or as a resident or as a faculty member even, how do you take a meaningful step in the right direction without taking steps inadvertently or otherwise in the wrong direction? But in general, we think that there's probably a really important and probably unmet need, which is just on the education side of things, make people aware. And as a medical student, be thinking about these things. It's kind of the idea about think globally, act locally. Is one of my favorite kind of mantras, and I think that kind of holds true here as well, which is to say that there could be some really, some of the education side of things, just to understand and think through some of the ethical challenges, some of the financial challenges that we've kind of are aware of, but that ultimately, hopefully, that can kind of form your medical base of knowledge and be additive to what you are learning in the classroom and in the clinics. And then if you have the opportunity to go on international experience, that could add to that as well, obviously, but that in and of itself, there's important learning to be had. So that's kind of just a little bit of a nutshell of kind of what we have been talking about hopefully trying to do. And so it's very much open ended. And we think all learning is good learning in this way, and are looking forward to kind of the road ahead with this organization, and see what we can't do, but also what we can't learn along the way. So thanks.
Thank you everyone who is online and in person here. I think we're gonna wrap up the meeting. So you have about 10 minutes to go do whatever next commitment you have. I do. So I'll see you back in either with Dr. Corinteger's presentation in December, I think. December 1st. Yeah.
I'm gonna make sure I have it on my calendar.
Okay. And then we're gonna try to get Dr. Kovac as well. Kovac as well.
You know, another person that just occurred to me is Dr. Torline, Ron Torline. He's another one of the anesthesiologists, and he's been working to try to develop a sort of a medical student education.
All right. See you later.